and I am so delighted to welcome you all to this session. The Gender Identity Toolkit is something that the IGPM have been working on with Indigo and Pride in Practice, and with Practice Index as well, and it's taken up quite a lot of our time, but a lot of our time that we've been really proud to be able to do, because we think this is a really important thing for all practices and all of our patients as well. So to introduce myself, I'm Kay Keane, my pronouns are she and her, and I'm the practice manager at Alvanley Family Practice, and I'm one of the directors of the Institute of General Practice Management. I think I've got Jo with me. Jo?
You have. Hi there. Yeah, so I'm Jo Wadey. My pronouns are she and her. I'm a practice manager in St Lawrence Surgery. Been absolutely thrilled to be part of this project group, and one of the directors of the Institute of General Practice Management as well. So welcome everyone. Thank you.
And Robin is, I think she's in France, and we've let her have a holiday because she's worked so hard on the accreditation programme for practice managers, and we're going to talk about that a little bit after we've done the majority of the session. And Nicola is having a heck of a time, like all of we are in practice, so we're unfortunately she can't join us today, so we're going to crack on.
Sorry, Kay, can you just let Nicola in? She's in the waiting room now.
Oh blimey, all these responsibilities that I'm not very good at doing that. I'll have to think about that for a second, but I'm just going to let Luke introduce himself while I think about how I do that.
There's a few in the waiting room, I think, that wants to be let in, Kay.
Okay, I'm admitting all, I think.
Excellent.
Okay, Luke, are you there? Would you like to introduce yourself?
Yes. Good afternoon, everyone. My name is Dr. Luke Wookey. My pronouns are he and him, and I am a GP, and I'm also the clinical lead of Indigo Gender Service. So Indigo is the first primary care-led gender service in England, and we are a 2-year pilot service commissioned by NHS England, looking at a regional primary care-based trans health service currently, and we launched in December 2020, and since then we've supported over 600 trans and non-binary people within our service.
Thank you so much, Luke. And I don't think Hannah is with us today.
I'm here.
Oh gosh, of course you are, Hannah. Please introduce yourself.
I'm Hannah. I use she/they pronouns, and I am the clinical nurse specialist at Indigo Gender Service.
Fabulous, thank you so much. So it's Amy that I don't think is with us. Is Amy here?
I am now. Sorry, I had multiple links in my diary, and I should have tried them before 2 minutes too. So hello. My name is Amy Linfield. My pronouns are she and her, and I manage the Pride in Practice program at LGBT Foundation, working with GPs and other primary care professionals across primary care.
Thank you so much. So these are they were the really important people that have worked with us and have all gifted their time because they absolutely believe in this as much of as us. And some of the other people that have worked behind the scenes that we really must just do a shout out to is Ali, who's our business manager, who has worked so hard pulling all this information together. So if you ever send us at the IGPM an email or a request, then it's Ali that'll answer those, and Ali works so hard to keep us on track. And then one of our regional reps, Kerry Chaplin, has also worked on this, and we couldn't have pulled it together and made it look lovely and glossy without the team at Practice Index. Just while we move through the session, there will be some opportunities to ask questions, but as we've got loads and loads of people, we think the best way to manage your questions will be to ask them in the chat, and then Jo and Ali are going to go through those questions and pick up any themes. We've also managed to get some questions from our members as well, so we'll be able to come to those at the right time. So we're just going to really dive straight in and start talking about this toolkit. We hope all of you have managed to look at it already. So Luke, why is this so important?
We've developed this toolkit because there is often a lot of kind of misunderstanding, myths and miscommunication between kind of healthcare professionals and trans non-binary people on what people's rights are within trans health in terms of changing their information on their medical records. We wanted to clarify and hopefully simplify the process for practices. So with this toolkit, we've brought together the most up-to-date advice and guidance from public and professional bodies, including the NHS, Public Health England and the GMC, to make sure that the care of transgender and non-binary patients within practices is managed respectfully and appropriately. So the toolkit provides that kind of optional resource, and it's very well referenced within the policy with clear kind of links to all the guidance that we've used.
That's fabulous, thank you. And that really is key as well, that everything we need should be in that one place. So all the organisations involved, all the guidance, all the kind of government websites, the NHS England ones, everything is available in that toolkit. So once we've got this should be the kind of single point that we can go to get things right. The other bit that I really like is the pronouns section as well, because that's one of the things that I'm always nervous that I'm going to get wrong, or I'm going to feel bad because I get it wrong. So I think that section as well, and that kind of information to share with our staff, is important too. And maybe
Hannah's good. Sorry, Kate.
No, go on, Hannah.
I was going to say Hannah's going to talk about later slide of just some of the key terminology that we use within trans health, and including pronouns within that, because as you say, it's just vitally important that we use the right and most up-to-date terminology when we're talking to and about our patients.
Fantastic, thank you. So you work at a gender clinic. So what happens if one of our clinicians refers a patient to one of those clinics? What happens when they get there?
So I'm going to talk a little bit historically about what happens, and also what's changing, because the landscape of trans health services is changing across England with the multiple regional pilots. But historically, what would happen is that a patient would go to their GP or primary care provider and want to be referred to one of the gender clinics. And at that time, they would be able to be referred to any of the 7 current national GIC, so gender identity clinics across England. But only there have been the development of 5 trans health pilots. So in order of the services going live, it started with Trans Plus, which is based in London, and then Indigo Gender Service, for which Hannah and I work for across Greater Manchester, C Magic, which is within Cheshire and Mersey, and there's also more recently an East of England pilot and a Sussex pilot. So currently 5 regional pilots in addition to the 7 national services. So it is worth finding out if you do have a local pilot. What's happened within Indigo is that we've been currently working on historic waiting lists. So those patients that were referred to a national GIC but not had their first appointment. As I said before, we took over 600 patients over, and we've worked through that historic waiting list. But now we're moving forward to looking at.
Oh, look, Luke, you're really breaking up for me, Luke. I don't know if that's the same.
Active waiting holding list that we can.
Sorry, Luke, you're really breaking up for me. I don't know if that's the same for. Yeah, everybody's saying same for us.
Right.
Hannah, I don't know whether you could pick some of that end bit up.
Yes, sorry. There's pilots in the east of England and Sussex as well. These are in addition to the 7 already existing GICs in the country. Was there anything else that we wanted to add, Luke?
I think he's frozen completely now.
Cool. Let's go to the next slide and we can talk about pronouns.
Okay, so the next section was about when we change their medical records. I don't know if Luke needs to do this, and I'll go on to the next slide for you.
No, that's fine. I'll just talk about the pronouns here, and then we'll go on to the changing medical records, if that's okay.
Yeah.
And I think this is, as you said, something that a lot of people sort of are a little bit nervous about, because people don't want to misgender people, because it can make them sort of, feel a bit invalid. And so common pronouns would be like she, her, he, him, they, them. Some people use combinations, so I'm happy for she, her, or they, them. And if in a particular context you're not sure what pronouns people want to be addressed by, you can just ask them what pronouns do you use, and people are generally really happy to be asked that question. A few more keywords to define just before we move on is so transgender is an umbrella term that refers to people whose gender identity does not completely match the sex that they were assigned at birth. So if you were assigned female at birth and you identify as anything other than female, so male or non-binary, then you are transgender. Non-binary people are people who identify somewhere outside of the male or female binary. So, they could identify as sort of neither or both, or sort of a fluctuating sort of between the two. Cisgender, this is something that a lot of people don't know, is when it's sort of the opposite of transgender. So if you're assigned female at birth and you identify as female, then you're cisgender. So most of the population is cisgender.
Okay, and I think you were really clear, and it's something that is good for us to hear, that actually if we get it wrong and someone puts it right, then let's just apologize, let's just say sorry for getting it wrong, and make a note not to in the future, and to ask as well. If you're not sure, there's nothing wrong with asking that in that situation, is there, Hannah?
Mm-hmm. Yeah, and people would much rather that you ask than sort of guess or avoid using pronouns, or people would much rather that you ask. And so trans people, so sex assigned at birth is it's well, it's complicated, but essentially when you're born, you are assigned sex, which is either male or female, often sort of with a combination of things, which will be chromosomes and hormones, and sort of secondary sex characteristics, primary sex characteristics. But the problem with sort of talking about sex assigned at birth is it implies that everybody fits into one of two categories, which plenty of people don't, and it's just a bit complicated, because if you say, oh well, women are people who have this part and this hormones, well, actually plenty of women do have elevated testosterone, like for example in PCOS, and plenty of people are XXY chromosomes, and they have various so it's quite hard to sort of say what assigned sex at birth is, but generally for most people they're assigned either male or female at birth. And so what trans people often get is like this gender incongruence, where they feel differently than how people are treating them, and that causes like a really it just causes distress. So if you're a trans woman and people are constantly saying sort of he, him at you, and treating you like a man, it can be really distressing.
Absolutely.
And so just one more point is that when people transition, this is something that is when they are known as their sort of birth sex to being as their desired gender. And this is something that can be a medical thing, but it can also not be a medical thing. So if somebody is not choosing to have surgeries, hormones, etc., they're still trans, and a transition isn't something that's like it starts and then is finished. It's like it's a thing that sort of continues to go on. So and we'll get into that more later when we discuss, you know, you have to have like proof of transition, because like it's sort of impossible to have a proof of transition, because transition means things to so many different things to different people.
I get that. Fabulous. I think Luke might have appeared back on. He does. He says he's back. Are you there, Luke?
I'm back. So apologies for that. Can you hear me okay? Is this better?
Yes, it is. Thank you. I don't know if there was anything in addition that you wanted to talk about. I mean, particularly what do we do if somebody approaches us and tells us they are in the process of transitioning, or they're transitioning, or, you know, what do we do to their medical records?
Mm-hmm. So it's really up to what the patient wants. You know, we have to be respectful of the right for trans and non-binary people to change their name, their title, or their gender marker on their medical records. So it's really, really simple for someone to change their name or title on their GP records. They don't have had to have changed their name legally. They don't have to provide any proof like a Gender Recognition Act certificate to do that. So they can verbally request a name of change, or a written request to change their name or their title. It's really important to use the title that the patient wants to use as well. We've had multiple examples of people requesting a title change, but being told we can only change it to MX, not to Mr. or Miss or Mrs. For a trans or non-binary person. Some non-binary people want to use the title MX, and that should be respected. But if a trans man wants to change his title from Miss to Mr., that should be that should be done as well, and the same with name change.
Okay. And what's the barrier of us doing that, do you think, Luke? Is it something that we're worried about screening, or, you know, why don't we do that bit?
Mm-hmm. Well, this bit comes on to where we're talking about gender marker change. So that is slightly different. So if you change a name or a title, that is not linked to screening recalls. So that will still keep them in line with all their screening.
Yeah, that's fabulous. Just to clarify that as well, I think PCSE, you'll know those that acronym, won't you? PCSE, Luke, that they will reject those changes and say, well, that can't be for that particular person. So we sometimes feel like we're constantly in battle with what the patient want and what PCSE think.
Mm-hmm. Yeah, it might be, if that does happen automatically, that you have to contact PCSE and explain that the patient has requested this and they're not yet ready or don't want to change their gender marker, because they are two very different things.
Fantastic. And if somebody does want to change them, is there anything we have to have from them? We don't need deed poll entries or anything like that, do we?
No, there's been lots of examples of deed polls being requested, people saying, people being asked, you know, if they've had surgery, are they on hormones? A trans or non-binary person doesn't have to be on hormones or have had surgery to change their name or title. And actually it can be quite offensive to ask, you know, people, especially at reception windows and so on, whether they've had kind of certain surgical procedures.
Yeah, I can just see that Jenny's just mentioned in the chat that there's an established process at PCSE. I think, yeah, there is, but sometimes it's it does cause us a problem in practices. So yeah, we can push back with them about that. So gender markers. So how is that different? So we know we can change their name and their title, but what's this gender marker and how do we do that?
So gender marker is changing from male to female or from female to male. So again, if a trans person or non-binary person wants to change their gender marker, they're entitled to do so. But there are some implications of that, both because by changing gender marker, our NHS number is linked to our gender, to a gender. So by requesting a change of gender marker, we also need to get a new NHS record. And this is all clearly documented within the toolkit and also on the flowchart that we've developed to support practices as well. So therefore, you do have to contact PCSE, fill in the online form and formally request a new NHS record, and then deduct the patient the original NHS number. But all the information has to be transferred over, all relevant medical information, to their new NHS record. But we have to redact any information or details of their previous name, gender marker and NHS number. So that can be quite a process, and it is the responsibility of individual practices currently to do that process. But I liken it to when a patient changes surgery and we do summarizing of medical records. You know, we're not word for word transferring all the information. It's important diagnoses, allergies, and so on and so forth. So very similar to summarizing, but redacting some information relating to previous names and genders, etc.
Okay, so that's on that's kind of a computerized summary. The paper records of the individual's dead name, does that go back to PCSE and they keep hold of, or do we then have what do we have as paper? A new empty envelope?
I think that's what happens, Kate, because you're deducting a patient, is sending the record back, and then PCSE will send a new record.
Yeah, and I think there can be a conversation with that individual as well, can't there, about you know, what is important to save, what is it that you're happy to have in your
Yes.
new identity.
That's the thing. We've recommended within the toolkit that there should be a clinician and an admin person. That clinician could be a GP or practice nurse that is aware of the process, because there are some potential implications in terms of medical information not being transferred over, or what the want is of that patient in terms of their new medical record. And I think if you have a discussion with the patient, most understand the importance of kind of really significant medical information going over, and the significance of screening and recalls and so on. So there is some nuance to it, and what we want to do on the back of this webinar and the back of the toolkit is develop some kind of frequently asked questions to try and answer some of that nuance, because it is difficult to put within the toolkit. But some potential implications may be medical information being lost, important information such as allergies, screening recalls, as we've said, unawareness to clinicians about what body parts someone might have, you know, if there's no reference to their previous gender, and implications on kind of health promotion and chronic disease prevention as well. So that discussion needs to happen with a clinician to make the patient aware of the potential implications. Okay,
and I think safe to say that every person that's going through this would much rather have that conversation and you know, be spoken to by the admin lead and the clinical lead, rather than losing that information. To have that conversation is much more appropriate, isn't it? Okay. How about recalls, screening recalls? That was the next kind of question we wanted to ask you. How do we make sure that that's all correct?
This is a bit of a tricky one, because if a patient does change their gender marker, they will fall out of organ-specific screening that's related to body parts that they may have. So, for example, a trans man or a non-binary person with a cervix, they change their gender marker, they won't be recalled for cervical screening. So you would need to opt the patient in every time that needed to be done. So it's a real kind of health inequality that trans and non-binary people face due to the kind of technology and the systems that we currently use within the NHS. And I know that this is being looked at to try and make this kind of a fairer process. So currently, like I say, they'd have to opt in. So for cervix screening, breast or chest screening, so trans women or non-binary people on estrogen, we may have to opt in if they haven't changed their gender marker. But for trans men that have changed their gender marker and have not had top surgery, or still have some chest tissue there, then they would need to be opted back in. So it can be a tricky process, and each practice works in very different ways. So there's no one easy solution, but the practice should have a policy about how they ask patients whether they want to be opted in to that, and that may be putting the onus on the patient, which is not always ideal, looking at particular recall systems within practices, and trying to develop some way of making sure that people aren't kind of falling through the cracks when it comes to screening.
Okay. That's great, thank you. And you said opt in each time. Did you mean for each individual or each time the screening's due?
So each time the screening is due, they would need to currently be opted back in.
That's horrendous. That's just that's the kind of stuff I would forget. You know,
Exactly.
so I suppose that practices would need to have another database of things to remember to do, or different recalls. Yeah. Okay. So much to think about. So I'm not sure if this one now, if we're going to Amy or if we're still talking to you, Luke. Are we doing a double act about best practice?
I believe Amy was
happy either way.
Do you want to pick up on this, Amy, and then
I'll pick up on this to give Luke a bit of a break, and then if you want to jump back in to add to anything that I haven't mentioned. So as I said at the start, my name's Amy Linfield. My pronouns are she and her, and I manage the Pride and Practice team in Greater Manchester. So we deliver training on LGBT inclusion across primary care. So many of these questions we do come up within our training sessions. I'm just seeing there's lots and lots of really good questions coming into the chat, and I won't sort of address them all, but they're very, very important and valid, and it's good to find a space. So one thing that best practice looks like is about finding that space to ask those questions, get those answers, and discuss these topics as a team, as colleagues, and different things. And I'll touch on that a little bit later. But in terms of sort of our sort of North Star for best practice, it really comes down to patient-centered care. We wanted to right by our patients. We want to make sure that they're included within decisions around their healthcare, and that they feel as if they are being respected, they're being accepted, and included. Otherwise, we do know that many trans and non-binary people will experience barriers where they don't want to engage with practices. We want to make sure we're minimizing that. It's also very important too that we are having medical considerations, especially when it comes to screening. So often when I talk about what best practice looks like, there's four real key points I make, and I mentioned a couple of them already. And one is education. So making sure that we're looking for these answers ourselves, whether that's through using resources such as this toolkit and networks like the IGPM, or whether it's getting Pride in Practice or other people to deliver training, or doing it within our services ourselves. Education means that we can look at these and try and find answers to support people. So that's one of the key principles. We've also been talking about ensuring that we don't miss people out on cancer recalls and different things that may be related to organs that they have. Unfortunately, a lot of NHS systems are based around the idea that male bodies look like this and female bodies look like that, and that isn't right for anybody really, whether we're talking about trans and non-binary people or cisgender people. We all have different bodies. But it is important that we're aware who our trans and non-binary patients are, and that's why monitoring on new patient questionnaires and different things are so important. If you are conducting successful monitoring and giving people that opportunity to share, one, people feel as if they are being accepted and can talk about the experience of a trans and non-binary person, but it also gives you that opportunity to do a search, for example, for your cohort of patients who are listed as male, but have disclosed a trans status, or said that their gender was different or is different to the one that was assigned at birth. And that will then let you find that group of patients. And again, we come back to that patient-centered care, having conversations, offering screenings, having flags on the system to have those opportunistic conversations. So they're two very key important principles. The other principles that we do sort of really promote in Pride in Practice training that I want to just mention briefly here is making sure that the language that we use, our language that isn't going to create barriers for people. So using gender neutral terms, if we're not too sure what pronoun someone uses, find opportunities to ask somebody their pronouns, and just try not to make any assumptions with the language we use. And this works for many different patient groups as well. So open questions is a really key principle. And the last key principle, which is possibly the most important one, is just make sure that on our sites, whether it's websites or physical sites, we're really demonstrating visible inclusivity. We want our trans and non-binary patients to feel that they can have conversations about their healthcare. So even just having a poster or a rainbow lanyard or something that really reiterates that you are open to have conversations that are relevant to healthcare for trans and non-binary people can make people feel that they can open that up and have those. So that's really just that's an hour session put into hopefully 3 or 4 minutes. But there's a few things there to think about. And as I say, it is part of a wider process of increasing our knowledge and increasing our information that we will be continuing.
So Amy, that Pride in Practice kind of training thing, I can see in the chat people are asking, how do I get training? So in some areas that's free and that CCGs or I guess local area teams pay for it. Certainly I'm fortunate to be in Greater Manchester, and we have had a wonderful relationship with the LGBT Foundation and Pride in Practice for probably about 5 years now, and we're just having our refresh with new staff. And that session really, to be able to ask, I guess I would class them as awkward questions, you know, the questions that you don't know how to ask, you don't know how to say it, you don't know how to word it, you know, really open the eyes of all of our staff. And I wouldn't just say that was the admin staff, that was clinical staff as well, to feel safe in that forum. So if you can get that training, please do, because it does make a real difference.
Yeah, just on that note about awkward questions, I've seen some in the chat that I can't talk about because of time. It's about creating that space to have those questions. We know that people appreciate just having that platform, and it's great that we've got a bit of that today. So we are funded to deliver training in Greater Manchester, the boroughs of Lambeth and Lewisham in London. If there's anything else, Ryan, you can pop it in the chat. And we're also funded to do some work in Essex currently, but we are doing work in other areas. And if you do want to know more, I will put the contact email in the chat too, so that you can drop us a line and we can extend the conversation at another time.
Yeah, nag your CCG if they're not ones that pay, because it really is such fabulous training. Sorry, Luke, did you want to come back on anything on that point?
Just one point that Amy mentioned about kind of and it's come up a bit in the chat about IT systems and coding and trans health status monitoring. Really important, but we know that our systems are not keeping up with this. I know it's really hard to code certain things within our IT systems and pick these up. So it's definitely an area that needs some significant work to make sure that we can really capture and pull that data, and it's done in a consistent way across all practices.
Just while I think about questions, there's tons in the chat, and they're all really good. And I'm going to give us all a job at the IGPM to try and pull those questions out and get some answers out as well. Sorry, team, if I'm giving us extra work, but I think it's really important.
Yeah, I've put that in the chat, Kay, actually, that we need to download it all and work on it as a group. No worries.
Brilliant. Thank you, Joe. And then I just wanted to show you, if you're absolutely snowed under with work, you don't know what to do, have a look in the toolkit, have a look at this flowchart of what you do at each point. This is the bit that needs to be in your, I don't know, your staff handbook, or, in your important documents. If you haven't got time to read the whole thing, concentrate on this. This is the one that will help you in the day job. And if you haven't downloaded the toolkit yet, you can get it from a variety of places. You can get it from our website, and you can get it from Practice Index as well. They're hosting it for us. And I think I've just seen that Ali's put the link in the chat as well. So please, if the words are all too much, this is the page that I think will help you the most. Okay, so Ali, have you got some questions from our members?
Yeah, I think what we'll do, these questions down here, let's collate them and send them out after. I think we've got so many coming in.
Yeah.
It's hard to pick out which ones.
Did we have some pre this session, Ali?
We covered those.
So we've covered all the ones. So all the other ones in the chat, we'll pick those up and send them after. And if there's anything burning questions that won't kind of rest for a couple of weeks, please do get through to us on our social media, and we'll try and pick those up before, if we've got a patient that may come to harm if you don't have the answer to that question, do let us know. Okay.
There's one from the chat. I keep seeing people saying they can't find the toolkit on the website. If they go to the latest news on the IGM website, scroll down, it's the very top download button. It's right there for you to just download.
And in Practice Index, it's not in the paid section, so you can just go and it's a free download. So again, I just want to say huge thanks, because these organisations, Indigo, Pride in Practice, we didn't have to work together, we didn't have to do this, but they've been so generous with all of your time and made a really, it's a bit of a monumental document. I think it's something that I think we should all feel really proud of, and just for us to know that we can come back to you and ask those questions and build that relationship is just fabulous for us as practice managers, and the IGPM can we can be the conduit for some of those if people don't know where to go. So I can just see some questions coming in about recordings and are we running another session. We intend this to be our only session about this, unless we look through all the questions and we kind of twist people's arms and say there's too many questions just to do a frequently asked questions. We might need to come back. So I don't want to say this is the end, because it might not be, but what will happen is this recording will go onto our YouTube account, and of course if these organizations want to share it as well, we're more than happy to do that. It's a shared resource to make sure that we do things better. I'm just going to whiz through these, Nicola and Joe, because I know we're just got 3 minutes left. So I just want to say a huge thank you to everybody that's joined as members. If you're not a member and you appreciate what we're doing, it's £50 a year to be a member of the IGPM, and all that means is that we can spend time doing this work on your behalf. So please go back to that website that Ali's put in the chat, and please do, if you can, join as a member of the IGPM, and we really are making a difference. Accreditation, we're nearly there, so we are going to be accredited managers. Practice managers will get that recognition. We're probably about 4 weeks maybe away from being able to announce that. We've got our first 10 regional reps and directors are going through that process of accreditation. So personally, I'm crossing my fingers that I get through that okay, and I've got all my evidence together. So we should be able to do a webinar early June, we hope, and then you will be able to be accredited with formal letters after your name. Then we really start to press NHS England about the new to partnership scheme and why we are being excluded from that. Some of you may know that Wales have invited practice managers to be part of that, their version of the new to partnership scheme. So we've got lots of ammunition now. The accreditation will just be the cherry on the top of that cake. So I will finish there. Lots of things you can do to help us, but really after today, the thing that you can do to help us the most today is go and look at your processes for patients who identify as LGBT. Look at our toolkit. Go and look up all of these terms that you've seen this afternoon and you've heard about. Find out what's happening in your area as well. And actually that will be the most successful outcome from this afternoon. So I guess you've all just about had